Hi there, this is Bree Cunningham at the OVBC Conference 2020. Have the pleasure of interviewing Dr. Sook on behalf of Dr. Kain. So, Dr. Sook, as I was writing down your information, I really was hoping that you were a hand surgeon because I have some carpal tunnel after that.
Yeah.
Holy smokes, you have a really interesting background and a lot of acronyms behind
Thank
your
you.
name. Tell us how you got in your role as the president of Geisinger.
So I'm the Chief Physician Officer at Geisinger for System Services, and I'm also the chair of the Musculoskeletal Institute, which comprises a number of different service lines within musculoskeletal health, including orthopedic surgery, physical medicine and rehabilitation, all the therapies, et cetera, et cetera. So I really occupy two roles at Geisinger. One is to run a very large clinical department, as well as on the hospital side, helping to manage as the clinical champion for a $1.5 billion supply chain and pharmacy services. So it gives me a little bit of different insight in terms of what is overall value-based care in not just orthopedics, but really just in general for healthcare.
Sure. Now, as an orthopedic traumatologist, did you start out operating and then just have interest in this subject, or did you always kind of have a dual-track mind of I'm really interested in the business side of healthcare as well?
That's a great question. So, as you know, I have a law degree. I also have a master's in public health and a master's in business administration, which I think the value of which is far more than just the degrees or the amount of study, but I think is reflective of maybe my interest in the overall way that healthcare was delivered. But at the same time, I also have a very burning desire to be a top of my field in the clinical realm, so as an orthopedic traumatologist. And so how you merge the two has been a kind of an interesting journey going forward. And I guess the best way to look at it is I love taking care of individual patients, particularly traumatically injured. I like to specialize in the complex revisions and the things that where things go wrong for other people and try to save those, while at the same time really looking at a more holistic way in healthcare, in the way healthcare is delivered, to try to make the system better and to try to create what everyone's calling value in a system that's very disjointed. And so all those interests kind of combine in the current role that I have.
So much of the work that's being done with value and bundles and population condition-specific management is related to elective procedures.
Yes.
So you're a trauma guy, and you also just said you like to do the complex cases, the revision cases, and typically someone that's part of a bundle shies away from those. So can you tell me some of the work that you're doing in your role with trauma bundles and the nuances of that?
That's a really great question, and great insight, because when we started this journey around bundles, we tried to pick those episodes that were really finite and relatively easy to control. And so total joints became kind of the poster child for doing bundles. You have a fairly standardized way you do things, a fairly standardized in terms of the way you postoperatively treat these patients. Trauma, on the other hand, is very different. You don't know what you're going to get from day to day. And at the end of the day, too, they all have a very different response mechanism, far less predictable. So the issue around trauma bundles is more so about looking at the total cost of care related to a condition, let's say hip fractures, which is a form of trauma. And is there a way for us to create certain algorithms to create surrounded by the best evidence to then say we're going to execute on these protocols every single time, and then we're going to overlay a cost analysis to see if we can do it within a reasonable sense of cost. So you maximize the outcomes by best evidence, and you decrease the costs, and now you're talking about increasing the value for hip fractures. And that's the birth of things like geriatric fracture programs and things like that. So what we're doing now is not only focusing on hip fractures, which was I would say the easier side of the fracture world to do this, very as close as possible as a joint kind of bundle, to now looking at greater, more complex areas. So is it possible for a infected tibial non-union to be bundled? And the answer is maybe. But the only way you can do that is if you're able to have insight and control over the means of production throughout that episode of care. So from the preoperative testing, do we do certain evidence-based testing to make sure that we understand what we're getting into on something like a complex non-union? To the postoperative protocols, which would include a patient compact where they're engaged and also involved in the care themselves. So things like smoking cessation after surgery or before surgery. So a lot of the lessons we've learned from total joints, I think, can be piecemeal accounted into a trauma world, to create a totally new animal. And I think that's the exciting things. And we have launched we have at Geisinger now a bundle around hip fractures, so we guarantee the care.
Okay.
We're looking at wrist fractures, rotator cuffs. We're looking at tibia fractures, and I think in the periphery.
What about the non-union that you just described?
And the non-unions, I was just about to say. So we're on the periphery. Yeah, we're looking at how we can apply the same principles that we're doing, and really tackle some of that complex care. Just as an aside, our first entry into the complex side was really on the joint side. So we, as you may know, have partnered with an industry partner to share risk on some of these episodes of care. So in 2017, we launched the world's first lifetime guarantee around a total hip surgery. In 2018, we launched the first lifetime guarantee around a total knee, the primaries. This year, in January, we launched the world's first lifetime guarantee around a revision total knee.
When was this?
January this year.
And you're a month and a half in, right? 2 months.
I'm sorry, January 2019.
Okay, 2019.
Yeah, it's
so
over
you're
a year.
And how's it going?
It's going great. So
really?
No complications. The patient's extremely happy.
Oh my goodness.
So we have some patients out there today, 3 patients who can claim that the world's first of something that the world has never seen.
Wow.
And this March, we're looking to launch a couple new exciting items around these episodic warranties that is going to be really fantastic.
Can you give a sneak peek or not yet? You can. Do it.
So this March, I'm hoping that we're going to announce a full all-comers, no restrictions 2-year guarantee on every total knee that we do.
Wow.
Yeah.
That's incredible.
Yeah.
I love that. You guys are doing so many innovative things, and I think one thing that positions you so uniquely is that you have access to all the data points, right?
Yes.
Because there's no middleman in there, which I think
Yep.
I love what you guys are doing, and it's going to be fun watching you innovate, and I'm sure a lot of people will follow once there always has to be an early adopter for the person who innovates.
I think that on that note, it's actually fun to be at the front. It's also scary sometimes.
Sure.
Right? So I'm very lucky to work in a system that allows and accepts a little bit of risk taking if it's for the right purpose.
Sure.
And
the revision thing is kind of crazy.
Yeah.
I realize that.
Yeah.
But I love hearing that.
Why
Why not? I love it. 1 year into it.
Yeah.
So I'm going to shift gears a little bit.
Sure.
We talked a lot about costs here at this conference and briefly touched on outcomes. You in some of your panel discussions brought this up. You're the author of 2 PRO books.
Yeah.
So you were always interested in kind of the science behind the tools. How do I understand that? But you made a comment in one of the panels regarding patient expectations.
Yeah.
And I would love to hear more about that and kind of the difference between a validated survey tool, patient experience, and what you believe are the metrics that that need to be incorporated into bundles.
Yeah, it's a great question. I think it goes back to kind of the origin of the books and why I chose to focus on patient-reported outcomes. So the first book was written in 2004, and I joked at the panel today that we sold almost no copies. It was me and my mom, and part of the reason why is because I think PROs are still a relatively new concept. The motivating factor behind it was really pretty selfish. It was based on the fact that when you were reading for evidence-based information, all of the evidence would cite some sort of random patient-reported outcome or some outcome measure, and then lo and behold, every conclusion said everyone did excellent. And you're like, I don't even know what they're measuring against. So the books were designed to help us make some sense out of all of that. The second edition in 2011, and we now are looking at a third edition, but still over time, PROs is still not a very sexy concept. It's kind of like the routine. And as Kevin Bozing said on the panel today, he said, we're really not doing a great job of collecting them. So we have an interest issue and we have a collection issue, although we think that the PROs, which are reflective of patients' outcome, patients-reported outcome, are very important. So if that is all true, then I think the next stage in where we need to go is not only find out what their opinion is, but I think it morphs into, is very directly related to what is actually important to the patient. Is it important that the patient reports a 75 on the KOOS score? Well, you'd ask a patient, they don't know what the heck they were filling out, and it means nothing. Is it important for surgeons to compare themselves based on a KOOS score? I got a 76, you got a 74, I must be a better surgeon? These are not really reflective, I think, of what's really happening in healthcare from a patient or consumer-facing perspective. And so I've been a proponent of looking at using those tools, but then enhancing it by cultivating and capturing something called patient satisfaction. And that satisfaction measure, I think, is reflective of not only the patient-reported outcome, the tool and instrument, but it's also reflective of how we set patient expectations before surgery, right? And then at the end of the day, we ask the critical question. Are you happy with what happened? And it's a pretty simple, it's the world's simplest questionnaire.
How do you like to ask it? From the answer option, do you do like a 5-point Likert, or do you like a net promoter type
It is
score?
a yes or no binary answer.
Really?
Are you satisfied with your care? And if the answer is yes, then you should feel good about an x-ray that may not look perfect.
Sure.
Or you may look if your KU score was 65. Because you put those two together, what's really ultimately important is that in the patient's particular condition and in the patient's individualized overall context, they're pretty satisfied. And that's what we're here to do.
Sure.
Right? We shouldn't be setting up, I think, a compare-contrast type of situation on metrics that are really meaningless from the patient's perspective. And I don't know how far I'm going to get with these arguments, because I'm, one who's been proposing that we continue to measure, which I think are very important, and it's really an important part of the journey. I think it's now time to overlay something that's pretty critical.
That makes plenty of sense, absolutely. And I would agree, as someone that has an outcome data registry, that question, have the results met my expectation, and would I do the surgery again, are two extremely powerful indicators, particularly over time.
That's exactly right. And, I'll just add one other thing, is that, as we look toward the future, so I recently gave a talk about patient-reported outcomes and why we at Geisinger were one of the first to integrate them directly into our Epic database. So we use a number of different softwares that capture outcomes across all musculoskeletal conditions. And it's not because I want a pretty dashboard or I want to go into my EMR. It's because I think the future will be very telling, in the sense that if I can match an outcome score with all of the data that I have in an EMR. So, for example, I just did a patient who's a BMI 30. She's a mother of 2. She's never taken opioids a day in her life. She's never smoked, but she has a history of slight depression, has been on antidepressant, and she walks 4 miles a day. And by the way, because we collect this information, we have her genomic code built into my EMR. So I do her surgery, and she comes out, and she has a PRO score of occlusive of 65. So in the future, with this database, I can say the next patient I get who matches that profile, more importantly, I can then tell them this is where I think you're going to be.
Yeah, this is what a 65 looks and feels like.
That's right. And so amazing. I think that's incredible for the future, and that's about collecting the data, putting it into some augmented intelligence format. But it starts with the data collection, and it's got to be part of what we do. And I think we have to constantly think about the bigger picture. It's not just a checkbox. It's actually really meaningful for the future of what we do.
Absolutely. I love it. So my final question for you. What is it that you love about Dr. Kain's conference?
So that's a great question, too. So I've been here now multiple years in a row. Number one thing I love about Zeev's conference is Zeev. I have rarely met in my lifetime someone as passionate about value-based care and multidisciplinary medicine, and rarely have I met an anesthesiologist who's so enthusiastic about orthopedics. I think it's reflected in the audience in that you have multiple repeat attenders. And it's the changing format, and it's the new ideas and the new topics that come up every year. I've told him this many times, and I tell him to his face that he's a real visionary when it came to this. I think he's put together panels of people who have been successful in their own pockets of life. And they've put us together, and we just get better. So I learn everything, the things I think people learn from me and my experience at Geisinger. But every time I come, I'm learning a tremendous amount from my peers. Like,
sure.
And,
Dr. Ficaro's was amazing today. Yeah, absolutely.
And we know each other through the circles, but it gives us a chance to collaborate a little more, too. So it's really a lot of fun.
He was hard on you this morning.
He was hard on me this morning. Hopefully I rebutted him pretty well.
You did. You did a great job.
I snuck on the panel just to piss him off.
I love it. Well, it made it a lot of fun. I sure enjoyed it.
Good.
Dr. Sook, thank you so much. It was a pleasure talking with you.
Oh, great. Thank you. Thanks for having me.